Good evening, everyone. I'm Dr. Atheek. Well, I'm going to talk on pre-planning, patient selection, and corneal marking for toric implants. I don't have any financial interest in any of the products mentioned here. Can you move the mouse pointer off? Yeah. Well, about 30% of our patients presenting for cataract surgery have astigmatism of more than 1 diopter. The options available for managing corneal astigmatism are, in case the patient has an astigmatism of less than 1 diopter, we can consider an LRI. For more than 1, the most reliable answer for that is a toric implant. But the reality is, every 4th case that we do, we should be implanting a toric implant. But in reality, are we really implanting that many toric IOLs? I don't think it is really happening. When we give glasses, we even correct 0.25 astigmatism, 0.5. We are very specific on the amount of astigmatism that we correct. But when it comes to correcting it with an IOL, the choice of a toric is not that much emphasized to a patient. Reasons being, one is, of course, in a country like us, cost is a major factor. The second answer is fear factor, which we aim to negate by doing such instruction courses. The quality of our vision deteriorates quite rapidly with astigmatism. You can see here that just a 1 diopter of astigmatism causes quite a significant visual blur. And it is even worse when the contrast sensitivity is less. These toric implants are quite reliable, quite forgiving, and they are the most accurate way of correcting pre-existing astigmatisms. So patient selection criteria, well, you can consider these lenses when the astigmatism is more than 1, or initially when we are starting, it's better to keep maybe 1.5 as the cutoff limit for astigmatism, and both the axes should be separated by 90 degrees, and preferably corneal topography showing symmetrical astigmatism. But I would say relative contraindications, patients with keratoconus, or we can consider a toric implant in patients where we know the keratoconus is not progressing. If you've done a C3R, followed up the patient for quite some time, and you know that the cylinder is not changing much, of course you can implant. And conditions where we get unreliable measurements, that is patients with dry eye. You can treat the dry eye or the ocular surface disorder first, ensure that the surface is well managed, or maybe put in a punctal plug, treat the dry eye first, and then you can consider doing a toric implant. In cases where there is progressive ectasia, it's better to stay off these cases. So what are the factors that we need to consider? Age is something that is very important. Most of us will drift towards against the rule over lifetime, or in other words, all of us will move towards a plus cylinder at 180 degrees. So when we put a toric implant in younger patients, it's always better to be less aggressive when we aim to correct with the rule cylinders. So what is this SIA? Well, when I want to throw a ball, maybe from here to madam, and there is a wind blowing from here to here, and it moves the ball from madam to this place. So that deviation that is caused is the SIA, or the surgeon-induced astigmatism. And initially we all thought SIA was limited only to the cornea. But now they've come out and said it is not only limited to the cornea, but also the implant that we put in, which could be caused by, say, a toric implant that is positioned, and that changes the astigmatism. And sometimes there can be laboring errors, which can change your predicted value that can occur, and some amount of tilt on decentration that can occur. Fourth, most important, the effective lens position. So to the cornea, what's important is superior incisions in general induce more astigmatism or change the astigmatism more than temporal incisions. Superior incisions change the astigmatism of around about 1 diopter. Temporal sections reduce the amount of astigmatism that we induce. Well, this data is from Dr. Warren Hill. If you're really interested in getting to know your personal SIA, drhill.com is available totally free of cost. We can enter the data and get our values. In case we have not, you don't know your SIA, you can assume 0.12 as your SIA. Dr. Hill says this is the centroid for most of the surgeons who are doing proper sections. I want to say very clearly, proper clean sections. And one more thing is, it is not only the astigmatism that changes, or in other words, it's not the 0.5 to 0.75 or the 0.75 to 1.25, it is also the axis that changes. So SIA is not only related to the magnitude, It is also related to the axis. Traditionally, all the IOL calculators available for toric implants were called fixed ratio toric calculators, or in other words, they were assuming that the lens is going to sit at this distance for all patients, irrespective of the white to white, irrespective of the axial length. And they were doing a correction for correcting the lens at the corneal plane, and then they were coming to a conclusion. This is not true. This is a big fallacy that is existing. Nowadays, the concept of ELP has come in, or the effective lens position. For each patient, a particular lens will sit at a different position. So the calculators have changed from fixed ratio to vergence-related toric calculators. Or in other words, the Barrett toric calculator and the Holiday 2 take into account the effective lens position and give us much more accurate values. So when you want to put a toric implant, the easier option is to go for Barrett toric calculator. It is available free of cost. This is a small example. You can see here that a lens that is supposed to correct 2 diopter of corneal astigmatism, say a plus T lens, when it sits as 5 mm ELP, the amount of power that will correct is about 3 diopters. And the same lens, when it is having a 22 diopter power, it is sitting at 4, will correct 2.5. So 0.5 is the difference for just a 0.5 ELP difference and a spherical difference of 12. So this is exactly what I meant. And another important prerequisite is biometry. Biometry should be precise, predictable, and repeatable. Now coming to keratometry. Keratometry is something that very important. Just a 0.2 mm of change in K value can cause a spherical shift of about 0.5 diopters. And the ever so reliable manual keratometer is definitely good enough to give us good predictable values. All of us will be having keratometers in our clinic. The most important thing is our keratometer should be calibrated. We can't buy it after 3 or 4 years, start using the keratometer for toric calculation. Definitely it will give us haywire values. And the user should be emmetrope, and the refractive power should be adjusted. And anything on the eye should not be put. The eye should be virgin. Even it is preferable not to do even a non-contact tonometry, because all these things change the ocular surface and give us haphazard values. You can see here this was a case where we tried to do K-metry after an applanation. You can see that the Myers are totally distorted. And this was another patient with a dry eye, and the patient is going on staring at the auto K, and you can see that the Myers get blurred. So in these cases, you have to tell the patient to keep blinking on and off so that the Myers get clear. You can see here the Myers are getting distorted, and this will give wrong values. So we should not put a speculum, encourage the patient to keep blinking, or put CMC, wait for some time, ensure that the cornea is wet, and then do. And all of us know there's a plus and a minus symbol in our K-metry. Aligning the plus on the other plus is quite simple. But aligning the minus is not so simple, because it may not sit exactly in the center. This is what we are supposed to have. The small minus has to sit bang in the center, but it can sit either this way or this way. Here there's a change in color, but actually both are fluorescent when we see on for the patient. So the easier way is align your pluses, rotate it by 90 degrees, and again take the values. You will get much more reliable way of doing K-metry. This is a technique which I learned from Arul sir when I was doing my training with him. So in manual keratometry, of course, we can get some detail which will tell you stay off that patient. Number one, look for the shape of the Meyer. The Meyer should be round and well defined. In case the Meyers are irregular, wavy, or distorted, or pulsating, or in other words, you're not able to align the plus and minus together, better to stay away from toric. And as of now, we have too many options for finding out the K value. We have the LensStar, we have the IOL Master, lot of equipments are available. If you are doing an ultrasound biometer, the ultrasound biometer is meant with the manual keratometer in mind, because the manual keratometer takes a reading at about 3.2 mm, whereas an IOL Master can take at 2.5 and a LensStar can take at 1.7 and 2.2. We cannot take a LensStar value, put it into the ultrasound biometer and expect to get proper values. If you are using a LensStar for all the calculation, you can incorporate the value that a LensStar is giving. Of course, right now we have very good swept source based OCT machines which actually give us the true K values derived from both anterior and posterior curvature. equipments available sometime back, or the models before LensStar 700, they were giving extrapolated values for the posterior K and coming out with values. But now these web source based OCT systems give us exactly the K that is needed to correct. And a word about posterior corneal astigmatism. If you don't have access to a topographer which can give you the exact K value, this was a trial which was done to compare all the equipments that we use as of now. And they came out and said that with the rule astigmatism was overestimated by all equipments, and against the rule was underestimated by all equipments except the Galilei. So with this in mind, Dr. Baylor came out with a nomogram to correct it. Of course, this table is available online. We can just go ahead and use the calculator. This has been incorporated with the online Barrett calculator. This takes into account the effective lens position, and the posterior corneal astigmatism has been incorporated into it. So we can no longer, we need not worry about the Barrett nomogram. Just enter the data into the online Barrett calculator. It will give you exact values where you will have to put your lens. All the data has been incorporated into this. And of course, keratometers in general read in mm, convert into D, assuming a refractive index of the cornea. So it's always better to enter K value in the keratometer in mm and not in D. And we'll know that the refractive index of refractometers also vary from 1.3375 to 1.332, which can give rise to a refractive power difference of about 1 diopter. So all these tiny changes can stack up together and give us huge surprises. So before we do, we need to get our basic act right. So is a topographer really mandatory to do a toric implant? Of course, the axis evaluation from a topo is much more accurate. If we have a topo, it is of course an added advantage, but if you don't have, it is, you can actually manage. So you can see here, there are 3 reference marks which are perfectly parallel, but which of these 3 is the one that we need to take? This with the freehand marking will cause errors. So the way we believe in doing is using a slit lamp. Align the Purkinje-Sampson image with a thin slit that is made with a slit lamp. Mark your, use a 26 gauge needle, mark it with your gentian violet, and then mark the cornea. This is a very reliable, simple technique that will give us extremely good results. And the patient, of course, finds it quite easy. It looks scary, but generally patients are quite cooperative for this. So the bottom line is, if you have access to all these fancy gadgets, of course, it is an added advantage. In case you don't have access, a manual K with a good technician with some amount of Baylor nomogram concepts in mind, we will be able to get through toric implants and give precise results. I'd like to thank AOS Scientific Committee and my mentor, Dr. Arul sir, for this opportunity. Thank you.